pathologists in our Health Sciences Center's SLP department. And I have with me as well Lorraine, who is another one of our SLPs here. Welcome to training for the swallowing screening team at Health Sciences Center. The screening tool that we're going to be using is called the Toronto Bedside Swallowing Screening Test, or TOR-BEST. And the training today is one of the components to help you become accurate and reliable in administering the TOR-BEST screening tool and to be comfortable using it. We have a few handouts here that you should have received access to. So bear with me as I share my screen. Here we go. You might have slides like this. You're welcome to use them for following along or taking notes if you like. And here is a form that you will become very comfortable with. This is our TOR-BEST screening form. All right, so before we really get into it, let me just say that if you have any questions today, feel free to write them down, hang on to them, and bring them along when you come to the next component, which is our live training. Our agenda for this morning, or today, I should say, is a few different things. Why do we do research in swallowing? What is it important for? What is a screening tool? A little bit about the development of this TOR-BEST, and a bit of information about swallowing, what it should look like for somebody with a normal swallow, and some of the things that can happen post-stroke, and how to administer the screen. First up, why research swallowing? Well, we know from research that approximately 55% of acute stroke patients have dysphagia, and swallowing disorders remain prevalent in the rehab and long-term care settings, with about 22% of residents in long-term care having dysphagia. Patients with dysphagia after a stroke are more likely to have pneumonia and therefore poorer health outcomes. But research shows that using a dysphagia screening tool with stroke patients leads to a reduced rate of pneumonia in acute stroke. Without a standardized tool, the decision-making for somebody's swallow and how to proceed can be time-consuming and inaccurate, because without a standardized tool, do we really know what we're measuring? So enter the screening tool. We're going to look a little bit about at what a screening tool should do, what should it be, who should use it. We want the screening tool to find the patients at risk for the condition that the screen targets. So in this case, dysphagia or swallowing disorders, we want to find 100% of the patients at risk for dysphagia. Doesn't necessarily mean that they definitely have dysphagia, but that they're at higher risk. We also want to have a tool that rejects patients who are not at risk for the condition we're targeting. So the screening tool should be specific enough that people who have normal swallowing will generally pass the screening. And we want the screening tool to be designed so that the results are, it's quick and easy to administer, interpret the results, and to score. Makes things easier for you. And we want it to be designed so that the results are consistent, right? So if you and your colleague both screen the same person at the same time, we want the results to be the same. We also want the tool to be acceptable to the patients being screened, right? We want it to be minimally invasive. We don't want to put them at risk of harm or even cause them significant discomfort. And then we want the screening tool to be accurate in what it measures. So the items on the screening test should reflect what it's testing for. When developing the TOR-BEST, the measures were developed to reflect specific features of dysphagia that would be most telling. Who should screen? Well, really any regulated healthcare professional who has received training in the use and interpretation of the tool is appropriate to act as a screener for dysphagia. And the screening, the training that you're receiving today is one component of the training. So why use a dysphagia screening tool? Well, we want it to help us triage those patients who are at higher risk for dysphagia and therefore need to be prioritized for a speech-language pathology swallowing assessment. The tool gives early identification that the patient needs to be seen. The screening tool results in the initiation of appropriate referrals, both to speech-language pathology and to a dietitian as early as possible. We know from research that patients with dysphagia are at higher risk for dehydration and malnutrition. And in fact, up to 50% of stroke survivors admitted to rehab from acute care may be malnourished. So it's important to identify patients at risk for dysphagia as early as possible, which then results in earlier intervention to address the nutrition and hydration needs. And we want the screening tool because it helps us reduce risk of harm. The harm might be because of the malnutrition and dehydration I just mentioned, or it could be harm that has occurred due to consequences of aspiration, like aspiration pneumonia. I mentioned earlier that stroke patients with dysphagia are at higher risk of pneumonia. So identifying these patients early on can lead to earlier swallowing assessment and then subsequent development of a management plan, which can then lead to improved outcomes of reduced pneumonia and ultimately mortality. Let's see here. When to do a swallow screen? Really, the best advice I have is that it should be done as soon as the stroke survivor is awake and alert by someone who is trained to administer the screening test. So that will be you. If you're wondering, is the patient ready for some food? Can I give the patient some ice chips? Or the doctor is saying, we need this person to have meds. It's time. If the person passes the screen, then they can eat or you can give them their meds. If they fail the screen, they should remain NPO, not having anything by mouth until they get a full swallowing assessment by speech-language pathology. And you'll hear more about that process, where to go from there when we have our in-person session. A little bit about the role of the speech-language pathologist versus the screener. So what you're going to be doing is the cut and dried, does this person have any risk, or is there concern for this person of dysphagia? Do we need to get SLP involved, or can we just treat this person as any other regular admit would? Versus what the SLP does, which is to do a more thorough evaluation or assessment of the physiology of the swallow and to figure out, well, now that we know there is some dysphagia there, what do we do about it? So how best to manage or treat. All right, moving on. Dr. Martino is the SLP who did a lot of the work in developing the TOR best. And before she got to the TOR best development, she had done an extensive systematic review of the literature back in 2000, which showed that specific dysphagia screening test components are more reliable than others in detecting risk for dysphagia. So based on that, she went on to start this development for the TOR best. The screening tool was piloted in Toronto at a couple of the hospitals there, Toronto Western and Toronto General, back in 2001. They found it easy to use and interpret, and that approximately 60% of the patients failed the screen, which is about what we would expect based on research that says roughly 55% of stroke patients will have dysphagia. So further projects were designed to assess the TOR best more thoroughly for stroke patients or residents in acute hospitals, rehab hospitals, and long-term care facilities. And then for about 4 years, there were validation studies that were completed at 3 acute teaching hospitals and 2 rehab teaching hospitals in Toronto. And finally, implementation testing conducted in 14 acute community hospitals throughout Ontario and 2 long-term care facilities. So having said all that, the basic thing to take away from that is that the TOR best has been thoroughly researched. It's known as a gold standard for good reason, and it's intended for stroke patients across the continuum, so right through from acute to long-term care. A couple things to think about. If you have ever wondered, well, why can't we just check the gag reflex to see if somebody can swallow? I can tell you that it's not an accurate predictor of dysphagia. When even people with a normal swallow, only about 60% or 2/3 of us have the gag reflex. And with in people who have an absent swallow, they may still have a gag reflex. You can think about the gag reflex is meant to get something out, the swallow is meant to get something in. So sort of the same parts, but different reasons for them. All right. I'm going to pass this off to Lorraine, and she is going to share a bit of the next stuff with you.
All right. Hello, everyone. So let's see, where are we at here while I get myself settled? Okay. There we go. So now that you know a little bit about what a screening tool is and how it differs from an assessment tool, let's talk about the conditions that we are actually screening for with the TOR BEST. That is the actual swallowing difficulties that you're going to see in stroke patients. So we're going to start by reviewing what normal oropharyngeal swallowing function is all about. So on your next slide, so in the review, I'm going to be discussing the landmarks and the stages of swallowing. And there you're going to see, okay, that's going to include the basic anatomy of swallowing. So let's start with the oral cavity. And the oral cavity begins with the lips and includes the teeth, the gums, the tongue, the hard palate, the soft palate, the uvula. So basically everything you can see in the mouth when you open, you go, ah, right? You're going to see all of that. So that's part of the oral cavity. It also includes right at the back, you're going to see the fascial arches. So those, when you open your mouth really wide, those are those two curved things that you're going to see right at the back, close to the uvula. It also includes the cheek muscles. All of these structures of the mouth are involved in swallowing. The lips hold the food and the liquid inside for the preparation of swallowing. The jaw and teeth cut the food up and chew the solid food and prepare them to get them just to be the right consistency, the right size for swallowing. Okay. All right, now moving along, the tongue actually moves the food under the molars for chewing. The tongue collects and it organizes the food and this into a nice cohesive little lump, which we call a bolus. And so that the swallowing can actually occur. The tongue forms a tight seal in the back of the mouth to prevent the liquid from actually falling down into the throat before we swallow. If it does fall down, then there's a problem. So in the next stages of swallowing, you look at the pharynx and the larynx. So those two areas, the pharynx being the throat, the larynx being the voice box, they contribute to the movement of the bolus into the upper esophagus. They close the entrance to the airway for safety so that the patient isn't going to choke or have food go down the wrong way and then develop problems that we're going to be discussing more later on. The closure of the airway is the body's safety mechanism to preventing aspiration or blockage or choking. Most of the movement during this stage of swallowing is invisible, apart from the obvious movement of the larynx on some individuals. So in men, what you're going to see is you're going to see their Adam's apple. The thyroid cartilage is actually coming up and down. That is the telltale sign that they're actually swallowing. Women, we're made the same. We also have the thyroid cartilage, but ours is actually thinner, and so it's more delicate. You can't see it, but it's there. And if you watch really closely, you'll be even able to tell when a female is able to swallow under normal circumstances. Okay. So this slide, which is also on page 8, shows the basic anatomy of swallowing. All right, so there are two structures that you may not be familiar with, the valleculi and the piriform sinuses. When talking about swallowing, it's really important to be aware of these spaces. Both are formed by muscular walls of surrounding structures, okay? It's also important to note that the hyoid bone is not attached to another bone, but it's suspended in muscle with attachments to the base of the tongue and the top of the larynx. So you kind of think that it's like kind of free floating up in there. It's a very tiny little bone right at the top, but it's not attached to any other bone. All right, so now let's talk about Okay, the physiology of actual swallowing. So there are 4 stages. So you've got the oral prep, right? So you've got the food in the mouth and you're chewing it and getting it all ready. Then you've got the oral propulsive. That's where you're starting to like push it back. You've got the pharyngeal stage where now it's actually in the throat and it's progressing down the throat. And then you have the esophageal stage where it's going down towards the stomach. So during the oral prep stage, the bolus is placed in the oral cavity to get ready for swallowing. This is where the food is chewed and masticated into that lump that I was talking about earlier, and that's called the bolus. The tongue holds the bolus against the hard palate while the lips and the jaw are closed, sealing the mouth. Okay, then you've got the oral propulsive stage. So this is where the tongue actually pushes the bolus from the oral cavity to the pharynx. So it's starting that oral propulsive phase that I mentioned. The movement of the tongue is kind of like a wave-like action. So when I'm working with patients, I talk to them about, okay, you're going to move that food around in your mouth like this. Then the tongue actually scoops it up, humps to push it down into the throat. And it's that scooping and humping action of the tongue that is actually the wave-like movement that we're referring to in the oral preparatory phase. All right, so in this slide, you can see the onset of that oral propulsion. So remember, I was saying the tongue, see, so you can see where it's scooping it up, and there's that little divot, and it's going to start to push it down to the back of the throat. So it's actually pushing the food against the hard palate, starting at the front of the mouth. This squeezes the bolus backwards, and you'll notice that the pharyngeal wall is kind of bulging outward to meet up with the velum. The airway is still wide open, and the opening to the esophagus, though, that remains closed. Okay, so now you'll notice that in this slide, the oral cavity is actually now completely sealed from the nasal cavity. You want that because otherwise you're going to have food coming up and out your nose. So together with the movement of the tongue, this results in the positive pressure. As the weight of the tongue moves from the front to the back, the bolus gets pushed farther backwards towards the pharynx. And as it reaches the faucial pillars, remember I was telling you those 2 round arches at the back of the oral cavity, the end of the oral propulsion stage is at that point, and the beginning of the pharyngeal stage occurs. Okay, so right now on this slide, you're kind of seeing the link between the 2 stages. But if you notice, the airway is still wide open. All right, so let's change this now. There we go. So now we're into the pharyngeal phase. And the pharyngeal phase of swallowing, you don't have control over this. This is now reflexive, and it's triggered automatically by sensation of the bolus at the back of the mouth. The pharyngeal phase occurs very quickly. However, it is very complex and requires a coordination of a sequence of movements. So now don't forget, this is what we're referring to is the normal swallow, what occurs in normal individuals. And I'm sure all of you are thinking of some patients that you've seen go, oh yeah, but they've done this, this, and this. Because the patients that you have seen that have shown any abnormality, their swallow is not normal. And therefore, any one of these stages can be affected. So during the pharyngeal phase, the bolus is squeezed down the pharynx, past the entrance to the airway, and into the upper esophageal sphincter. The UES is the opening to the esophagus. And this should actually occur in 1 second or less. But you know what? I've read some research that says it can take about 1 to 3 seconds. So we're going to take that little bit of information with a grain of salt there. So let's go. Okay, now, when you get to the mid-pharyngeal stage here, this is where this slide illustrates that you can see the bolus within the pharynx as the epiglottis moves downward, closing the entrance to the airway. This is important. We want the airway to be closed in order for a patient to be able to swallow safely and have all of the bolus go down to the stomach. So you're going to notice that the hyoid bone has moved up and forward because of the contraction of the muscles at the base of the tongue. It needs to do that. Since the hyoid is also attached to the larynx is drawn up and tipped forward with the movement of the hyoid. Within the pharynx, there is positive pressure created by closing off the nasal cavity, while within the esophagus, there's negative pressure. Ah, that's a lot of confusing information right there. But just know that there is this very complex sequence of interplay that has to occur with movement of structures and pressures that are going to create a safe environment for swallowing and having a bolus go down to the esophagus. By having the UES open, so remember, I was saying that's the opening to the esophagus, the bolus is helped to be pushed through the pharynx down via peristaltic waves and the pharyngeal muscles into the esophagus via vacuum, that the negative, positive, negative pressure effect. So the UES opens, the peristaltic waves push it, the base of the tongue has pushed it, the UES opens, and boop, down goes the bolus. Okay. So now we're on to the end of the pharyngeal stage. This slide shows the upper esophageal sphincter is now fully open. The epiglottis is deflected downward to protect the airway, and the bolus is moving into the esophagus. This signals the end of the pharyngeal stage and the beginning of the esophageal stage. All right, and during the esophageal stage, peristalsis again moves the bolus downward to the lower esophageal sphincter, which is the opening to the stomach. So again, under normal circumstances, when you have the bolus either in the pharynx or at the upper esophagus, that lower sphincter down by the stomach is closed. It's not until that bolus gets all the way down to the stomach that then it's going to open and then allow passage into the stomach. All righty, so just as a review, you now know that there are 4 stages in the whole swallowing process that speech pathologists evaluate. So we don't only say that they have a pharyngeal dysphagia. We look at the oral cavity too, we look at the pharyngeal phase, and we also consider the esophageal phase for swallowing. So if you think about the 4 stages, right? So we have the oral prep, the oral propulsive, we have the pharyngeal phase, and then there's also the esophageal phase. So let's take a look here. So now we actually have a slide of a normal oral pharyngeal swallow. So let's turn this on. Okay, and all right. So I'm just going to let you take a look here and watch this, and then I'm going to play it back again. Okay, so you actually saw a few things that are being identified there, right? You've got the airway, the tongue, there goes the liquid, whoop, down it goes, down it goes, gathering it up, and there's the swallow. Okay, so that was actually done pretty safely. All right, there was no cause for concerns with that swallow. So you would have seen, so let's just start that again. So come on back here. Let's see if I can get this all the way back. There we go. Brought that back too far. Okay, let's get back. There we go. So if we start, so you can see the mandible, right? And there you saw the hyoid bone, the epiglottis was pointed out. All right, laryngeal cartilages, all of those, then the tongue, okay? And then the liquid into the upper esophagus. Okay, so there we go, down safely. And again, good, okay. And we don't want anything to go into the airway, which is right here. And it didn't, because it was, that epiglottis was fully retroflexed and the airway was protected. And so all of that bolus went all the way down to the esophagus. All right. So let's take, what we're seeing in red is actually liquid. Okay, and now we're actually seeing a liquid bolus that is just a regular VFSS type of view. That's how it looks for us when we do our X-ray swallow studies, our video fluoroscopic swallow studies. And why is my screen black here? Okay, let's just advance that along. Oh, okay, so I went too far. Let's back this up a little bit. Okay, so, okay, let's play it. And sorry, we're going to go backtrack. There we go. And bring it along. Bring it along. Okay. That we did. There we go. Okay. And so yeah, when we do our video fluoroscopics, we don't have the luxury of a color. It's just black and white, but we do mix the food with barium so that it'll show up a little better. All right, so the next thing that we should be actually seeing is, I believe it's going to be a view of puree. Let's see here if that actually, nope, I guess not.
Use the next button instead of,
So let's try this.
or back, but
Yeah, I'm not sure. No, that's all right. So what we're going to do is we're just going to keep on going here. All right. So let's talk about what are impaired swallowing. So impaired swallowing can be caused by motor, sensory, or structural changes to the mechanism, as can usually occur following a stroke. And as you've seen in the video that we just watched, swallowing is very rapid and it's very complicated. So we talked about it, you saw about it, it happens very fast. When we're doing our video fluoroscopic swallowing studies, we often have to play them back and review them again. We also have the luxury of slowing it down because there, as I mentioned, there is such an interplay that we do need to make sure that we are watching and evaluating each structure appropriately. So any disruption in the timing or strength of the movement of any structures involved can cause a dysphagia. So here, let's take a look at this patient. This patient has had a bilateral cortical strokes, which have affected his swallowing. Based on his diagnosis, when we see this patient, we might notice that he has weakness on both sides of his body. He may have difficulty with communication. He may have difficulty seeing the food or even feeding himself. As you watch this video, see what difficulties you can identify while he drinks regular liquid. You're going to see the same swallow 3 times. The first time is in real time. The second swallow is in slow motion. And the third swallow is without color. All right, so let's go here. So there, you saw the yellow, that was aspirated. Now he's coughing. That definitely went the wrong way. So now you're going to see it again. So there you see it slowly where it entered into the trachea. And now he's going to cough. And let's watch it again. And let's see if that epiglottis completely trips down or flips. And it did, but not fast enough. The liquid went in prior to that epiglottis actually fully closing off the airway. Okay, so let's go on to the next slide. Okay, we are going to see the same patient that we just saw aspirating. This time he is drinking thickened liquid. So compare what is different from the regular liquid and how does his swallow change or improve? So let's give this a try. All right, so that's the thickened liquid. Now it's in the valleculi. He's getting ready to swallow. And there it goes. So did you notice that nothing was entered into the airway or the laryngeal vestibule? Nothing was aspirated. So also, did you notice that the bolus was a little bit slower in passing? It was a little bit heavier, a little bit thicker. For some patients, that's what they need. They need to have that heavier consistency in order for it to be able to swallow safely. His swallow is still delayed. The bolus still falls a little prematurely into the pharynx. However, no aspiration occurred. So let's take a look now at the same patient again with a spoonful of puree. Okay. There it goes down to the valleculi, sitting there. He's getting ready. There we go. And again, there was no aspiration that occurred. So we just saw a good example of the benefits of thickened liquid. It decreased the risk of aspiration. Thickened liquids can also have a partial risk of dehydration because a lot of patients don't like them. They're so used to drinking regular liquids that their actual overall consumption of the thickened liquids is less. And so they do run the risk of dehydration. And that's where we ask nurses and healthcare aides and whoever can be on the ward, please encourage them to drink. The three most common food textures prescribed for stroke patients are pureed, minced, and thickened liquids. You're going to hear that a lot with our stroke patients. But the one thing that is very important and often gets overlooked is a good oral care program. Oral hygiene is extremely important because I'm sure, as you all are very well aware, there's a sequelae of problems that can occur with poor oral care. Gum abscesses, tooth loss. You can have cardiac issues. You can have developed sepsis into the bloodstream. You can develop infections that transfer up and into the brain. Those are just a few off the top of my head. And there have been a few cases in the Health Sciences Center where patients have developed brain abscesses that have been directly linked to poor oral care. So oral care is very important, especially for patients with dysphagia. It stops the colonization of oral bacteria, it removes the food debris that can be aspirated, and it increases oral comfort. And a research project that I did here together with a clinical resource nurse specialist, Christine Johnson, patients also told us that they felt so much better, their quality of life was so much better with good oral care, that they felt horrible, and they felt that their illness was actually worse if they did not have good oral care or regular oral care. Okay, so the evidence does show us that oral care should be given a minimum of 2 times daily. However, if a person is at risk of aspiration, they should have oral care after each meal to reduce the risk of aspiration. I know that that's difficult given the huge time constraints that nurses are under. And that's where we look to how can we bring the rest of the healthcare team in. But it's the nurse's responsibility to ensure that it gets done. So the equipment that you would use for oral care can make a huge difference in how effective it is. Foam swabs do not remove the bacteria, either from the teeth or the gums. They're basically useless. And the best choice of equipment is a soft toothbrush or even a baby toothbrush. If patients come in and have poor gum health and already have a severe case of gingivitis, there's going to be a lot of bleeding and their gums will be tender. Infant toothbrushes often have bristles that are soft enough that they are effective in removing the debris, but they do not cause tenderness or harm. Also, there are toothbrushes available that have the suction component on it. So if a patient is at risk for potentially losing control and aspirating the toothpaste or aspirating any liquid, the suction toothbrushes will help to remove that to minimize the chances of that occurring. Dentures need to be scrubbed with a brush to remove bacteria. Soaking alone is not enough. And those patients that have no dentures or no teeth, they also need to have their oral cavity cleaned, because just saying, oh, well, they have no teeth, no dentures, we don't need to worry about it, just give them a drink of water or just, have them swish and spit, not good enough, because that's not removing the bacteria. The oral cavity must be brushed, whether they're edentulous or not, to remove the bacteria. And oral care is needed even after the stroke survivor is placed NPO. Yeah, the bacteria can grow, and the least of the worst of the symptoms is that their breath is horrible and they can taste it. But the worst is that the bacteria gets bad enough that then they can develop the sepsis or the abscess, as I previously mentioned. So a soft toothbrush with toothpaste is one of the best ways to give good oral care. However, if the toothpaste residue is left, then it will contribute to dry mouth. So there are many dry mouth products that are available that have no alcohol in them and are effective. But water is the best oral agent for moistening the oral cavity. So let's take a look at another person with dysphagia. Okay, here we go. So this patient has a left-sided pharyngeal paresis. This would be due to a right hemispheric stroke. Therefore, feeding this patient likely needs to be from his left side. People with right hemisphere strokes often have swallowing difficulties and have a greater risk of aspiration pneumonia. So as I run the video, you're going to notice that this patient has an NG tube, which is kind of outlined in red. And as you're watching, try to identify what swallowing difficulties he is having. All right, so let's turn this on. Okay, so is there residue in the pharynx? Are you seeing that? Is the repeated swallow effective? Does the residue increase as with saliva? What do you think? And the second swallow, residue, do you see it overflowing? Let's just wait for it, wait for it. Let's see if it's going to aspirate. Does it go down? Well, it's getting pretty close there. There she blows. So now it's been aspirated. So you saw that, and the patient's now coughing. Okay, I'm going to stop that. So you would have seen that thin dark line that went down the front of the airway. That was the aspiration. And fortunately for that patient, they had an intact cough reflex. They could sense it. So that was in that patient's benefit. Unfortunately, a lot of our patients have what we call silent aspiration, and they don't cough and they don't sense it. And sometimes the only way we can detect it is on our video fluoroscopic swallow studies. All right, so now we're going to take a look at a patient from an AP view. That's the anterior posterior view. What you previously saw was the lateral. So you saw them from the side. Now you're going to see them from front to back. So you can see that most of the residue is in the left valleculi. So let's turn this on. So it's going to be over here, right up there. Okay, and that the patient is instructed to turn his head to the left side as a treatment technique to close off the weaker left side, hoping that the bolus is going to be forced down to the right side. However, multiple swallows don't seem to significantly improve the residue. Yeah, there he's done his head turn, he's trying again. There you see the residue. It's not really, yeah. Okay, most of the bolus is moving down. Let's just take a look. Okay, it's going down the esophagus, but there's still quite a bit of residue that's hanging around there. And now he's looking back at us. Yeah. Okay. All right. So we're going to give that a stop. All right, so we saw that this person has an NG tube, and if someone is not able to eat any texture safely, then they may have to continue being fed by the feeding tube. So some of the risks of having a feeding tube is that they can still develop aspiration from reflux. They can still develop a pneumonia from that reflux, but the benefit of having a feeding tube is that they will get their nutrition and they will get their hydration. Whenever anybody has a nasogastric feeding tube, we always say, well, if you're going to be running the tube feeds, make sure the head of the bed is elevated so that the patient has less likely, it doesn't eliminate, but they have less likely of a chance or of a reduction of a chance of there being any reflux while that feeding tube is running. Because don't forget, remember, we mentioned the upper esophageal sphincter and the lower esophageal sphincter. That feeding tube is going through both of them. So those two sphincters, which are normally closed, keeping food from coming up where it shouldn't into the pharynx and airway. With the nasogastric tube going down, you now have it slightly open. Those two sphincters are held slightly open, increasing their chance for the bolus to come all the way from the stomach up, up, up into the pharynx and then being aspirated. So having the head of the bed elevated is really important. All right, let's take a look at the next slide. Okay, so this patient has had a lateral medullary stroke, a brainstem stroke. So this person's stroke has affected the area where most of the cranial nerves pass through. This is the area involved in life-sustaining functions such as breathing. So in the video that you're about to see, he's going to be given a teaspoon of regular liquid to swallow. So I want you to think about how the bolus is organized or not. Does the tongue lose control? Does some of the bolus spill over prematurely? The tongue seems to be working hard to seal the oral cavity off. Let's take a look and see some of these things that I'm talking about. Okay, so there we go. So the bolus is not organized, and some of it is starting to spill down, premature spillage. Okay, he has reduced movements of the pharynx, right? And also we noticed that only a small amount entered into the esophagus. He had residue hanging right around there. He's got stuff still in the pharynx there. So there's pharyngeal residue, and there's what we call piriform sinus residue. And you see that residue right there? There's follicular residue as well. Okay, so now we're going to have the same patient try a compensatory strategy. So sometimes we ask patients to do things that may help to improve the safety and the effectiveness of the swallow. So one strategy that sometimes we can do, depending upon where their difficulties are, is we can ask the patient to tuck their chin. You can't tell them to go all the way down, because nobody can swallow like that when your chin is right at your chest. But basically what I tell my patients is just pretend that you're looking at your knees. So when you tip your head down enough like that, you're looking at your hands on your lap, that's going to be enough of a chin tilt to get them to hopefully make it effective. So this is the same patient drinking from a straw. His chin is also slightly tucked downward as a treatment technique. So here we're going to notice that he's able to take a larger amount. Let's see how effective it is though. Okay, does he have, oh yeah, he still has some that penetrated. So his upper esophageal sphincter is still not opening well. More liquid is remaining in the piriform sinuses, quite a bit of liquid. As he swallowed, a small amount spills into the airway of the larynx, which we saw. The airway is a bit more narrowed, but not enough to prevent aspiration. So let me see here. And right around here, those are the vocal cords. And are they, yeah, they're dark because there's some barium on them, which means that the liquids actually did go and coat the vocal cords. If this man was speaking to you, he would probably sound very wet, or his voice would be very gurgly. All right, let's try this now. Is the same patient with a teaspoon of puree. So you will also see him do a head turn during the swallow. And his swallow was still very weak, and he has a hard time moving the puree because it is heavier and thicker. We're going to see what the upper esophageal sphincter does. So let's take a look how he does with puree. All right, he's having difficulty moving that bolus. It's premature spillage there. He's trying to swallow. Wasn't a very good attempt, poor guy. Now he has a lot that's hanging around in that valleculi. So right there, he has a lot that's hanging around in the pharynx and the piriform sinuses. His airway's wide open. He's at extreme risk of developing an aspiration pneumonia. Has he yet? It hasn't fallen in yet. Most of the puree remains in the valleculi and piriform sinuses. With a head turn and multiple swallows, some of the residue clears, but not all of it. So several things were tried there. We tried the head turn, we tried the chin tuck, multiple swallows. I'm sure he was being told to do an effortful swallow, to swallow really hard, but for this gentleman, it wasn't effective for any of the consistencies. So he is at risk for developing poor nutrition, because it would be very difficult for him to meet his nutritional needs orally. He's at risk of developing an aspiration pneumonia, upper respiratory infection, poor hydration, and even death, because as we all know, death can occur, particularly in the elderly or post-stroke, from an aspiration pneumonia. All right, so these were just a few examples of what a swallowing problem can look like. Hopefully, if you take one thing away from seeing these videos, it is that swallowing difficulties can be very complex, and that you can't always tell what is going on with the swallow just by watching someone with their meal. However, that is for the speech pathologists are all trained in doing clinical bedside swallowing assessments. So if the nurses ever have any questions, and that's where the TOR best comes in, that's where the speech pathologist would determine, is a clinical bedside swallowing assessment sufficient, or do we still have questions and therefore need to go to the next stage and doing a video fluoroscopic swallow study? So that's why the hospitals decided to move forward with implementing the dysphagia screening tool that is evidence-based and has been proven to be effective. If that risk for dysphagia is revealed by the screen, the patient then goes on to receive the swallowing assessment by the speech pathologist, which will determine the type and severity of dysphagia. And based on those findings, the treatment plan or further assessments will be developed. All right, so now I'm done for now, and I'm going to pass it back to Suzanne, and I will see you all at the next stage when we have our in-person practical experience.
All right, I'm back. So you saw a little bit about what a swallow should look like and some of the things that can go wrong. We're now going to take a look at the screening tool again. This is what the form looks like. We're going to talk a little bit more about that form in a few minutes, get some more details. So the TOR best, as we said before, is intended to be quick and simple, to be used as a screening for dysphagia post-stroke. There are two main components, sort of in three parts for this test. The first and the last parts include examination of the mouth and the voice, and the second is a water swallow test. So scoring is pretty simple. There's, for each task, there's a choice of just abnormal or normal. For example, abnormal following a swallow of teaspoon of water would be a change in voice or a cough, a throat clear, or drooling. And if none of those things happen, then it's normal. Determining pass or fail on the test is also pretty easy. Any one abnormal score on any item equals a fail. So if all of the boxes are ticked off as normal, then it's a pass. But at the first sign of anything abnormal, you just stop right there. It's pretty quick. Average time to administer and score the test is less than 10 minutes. And it's 1 page long, going from top to bottom with tick boxes. As we go over the TOR best, we're gonna take a look at each step. So we start by filling out the top of the form with the patient's identifying information, and then we record the date and the time. Next part A. These are even before we start any oral intake, any water trials. Having the patient say ah and judging their voice and having them stick out the tongue. So the first step, you want to judge vocal quality. Tell the patient, I want you to say ah for 5 seconds using your speaking voice. You don't want them to try to sing ah. You want to assess their real vocal quality. And to help them understand what you're looking for, you can give them cues like modeling, say ah, or you can tell them to stretch the last syllable of the word Ottawa. You can remind them, no singing, I just want to hear your voice. And you want them to use a loud enough voice that you actually have something to assess. All right, if the patient can't follow the command to say ah, for example, they have aphasia, they don't understand what you're asking, you can note any vocal noises and judge vocal quality from those. So it's important to pay attention to the speaking voice, even before you give them any trials, before you tell them what you're doing, and note what their voice sounds like prior to having them say ah. What are we looking for when we listen to the voice? Well, we're looking for breathiness, gurgles, hoarseness, anything that really seems abnormal, or even you might sometimes often come across patients who you think, oh, this is probably the person's normal voice. But if you're listening to that voice and you think, oh, I wonder if she has a cold, or he sounds like maybe he's a smoker, or if you think, oh, wow, that's a creaky sounding voice, that would automatically be something that you score as abnormal. So no making guesses about whether or not this is the person's normal voice, even if you got in your history that this person used to smoke for years and years and years. All right, we are going to watch a video here, and let me just make for sure that I am sharing this with sound. There we go. Okay, so here, this is somebody that we are going to listen to his voice.
Okay, so we're going to do a quick screen of your swallowing. First thing I need you to do is say ah.
Ah.
Okay, now I want you to hold that for about 5 seconds, like this. Ah.
Ah.
Okay, so what did you think? Normal voice? I would call that normal. If any of you thought it was abnormal, you know, if there is ever any doubt about anything, score it as abnormal. But this is what I would call a nice, clear, normal voice. All right, so what's next? Tongue protrusion. Here we want to ask the patient to stick out your tongue and then move it from side to side. So you might start by saying, open your mouth. Now stick out your tongue as far as it will go. The tongue should protrude straight out, so you're watching for deviation to one side or the other. And even if there's just a mild deviation, you're going to score it as abnormal. Okay, so you've asked the person to open the mouth. You don't want them to keep their lips tightly around the tongue and support it. If the patient is unable to protrude his or her tongue at all, then we score that as abnormal. If you see deviation on protrusion, we score it as abnormal, and we skip the side-to-side movement. So we have here a picture of normal tongue protrusion. Note that the natural fissure down the center here is exactly at midline. Here we have abnormal tongue deviation to the left, ranging from mild here, more moderate, and more severe. And you can see that the tip is pointed to the left of midline and the fissure is not midline. Similarly, we have the same thing with tongue deviation to the right, ranging from mild to severe. And if the tongue has even mild deviation, like I said, right or left, if it's even just a little bit, we score that as abnormal. Next, we look at lateral tongue movement. So we cue the patient, move your tongue side to side like a metronome, and you can give a visual example if you want. Right? And we're looking for preference of movement to one side or signs of effort in moving the tongue to one side. If you see either of these things, we score that as abnormal. And here we have another video. Take a look, see what you think.
So the next thing I need you to do is open your mouth and stick your tongue straight out. Good. Now I want you to move your tongue from side to side. Great.
Okay, so what did you think? That was what I would call normal tongue protrusion and movement from side to side. But like I said, if ever there were questions and you were thinking, was this normal or wasn't it? You would score it abnormal. Okay, so once the oral peripheral exam part of the test is complete, we move on to the water swallows. And this includes up to a maximum of 10 trials of water by teaspoon, and then some cup drinking of water. If at any point during this part of the testing, the patient coughs or has a change in vocal quality or drools or throat clears, then that's when you stop the test and you check in the appropriate boxes. So make sure that the patient is positioned as optimally as possible during the water swallows. Ideally, you want them upright in bed or a chair as close to 90 degrees as possible. If you need to use pillows and props like that to help stabilize them, you can do that. The teaspoon of water has to be fed to the patient by the screener. We don't want them to self-feed the teaspoons of water for this screen. And when you're giving the first few teaspoons, you can lightly touch the neck to feel for upward movement of the larynx or Adam's apple, like Lorraine was mentioning before. When you're doing this, you might just want to make sure the patients don't go like, lift their heads up. You can tell them just look straight ahead. What you're feeling for is that laryngeal movement to see is the swallowing happening. Or you can watch for it, that's okay too. On some patients, particularly those who have had a brainstem stroke, this movement of the larynx might not happen, and that means that the patient isn't able to swallow. So after each teaspoon of water, you want the patient to say, ah, and you're listening for any obvious change in vocal quality, suggesting wetness after any of the swallows. You're listening for coughing or throat clearing during or after a swallow, and you're watching for drooling as well. If you observe any of those things, even just one, that means an abnormal score for that swallow, and you would stop the test there. Aside from the signs of difficulty that we've already mentioned, there might be other reasons to terminate the water swallows. If at any time you have concerns about the person's ability to tolerate this part of the screening, you can stop giving the water, you can record the reason beside the number of the last bolus given, right? So the person all of a sudden had a decreased level of alertness or whatever it is, feel free to make a note in the margin, just document what you saw and leave that at that for the time being. You can always come back to the screen 8 hours later or next shift, next day, and try again if the SLP isn't already there. But yeah, if you have concerns, you can always stop. Another reason to terminate the test might be if the patient declined further participation. Again, you would stop the water swallows at that point and record the reason beside the number of the last bolus given, right? So if you're looking at this screen here, let me make that a little bit bigger. Say you got through the water pre-water intake, the tongue sticking out. The first 3 swallows were normal, and then the patient said, I'm tired, I just want to rest, or I don't feel comfortable doing any more of this, or whatever it is. Increased respiration rate. Oh, and here we're wondering, did something go down the wrong way and we didn't notice? There was no cough, silent aspiration maybe. Whatever happens, you're just going to mark normal as much as you got done, and then make a note on the margin. Back to the slide. Just a note that stopping the water swallows, even if it wasn't because of something that the screen specifically tells us to look for, if it was because the patient just got fed up with it and said, let's quit here, that counts as an abnormal result. So if you do the screen again later, say 10 o'clock at night, now the patient wants more water, and so they're willing to try again, SLP isn't here, you can do the TOR best again, and you would start from the beginning. All right, what else? After providing the patient with 10 teaspoons of water, which they have successfully swallowed and were scored as normal, then you offer the cup to the patient. Ask them to take 1 sip. After they swallow and say, ah, again, you're looking for any wet voice quality. You're noting any cough or throat clear, and you're noting any drooling during or after the cup sip. If there have been no abnormal results in this section, then you check off the normal box for each swallow, right? So that's down here till the 10th teaspoon and for the cup drinking. At most, let me get back to the slides. At most, there should be 3 boxes marked for each teaspoon of water. So if any one of these 3, right, cough, which maybe includes throat clear and voice change and a drool, If any one of those boxes is checked off for a particular swallow, that ends the water trials. All right, so let's take a look at some water swallows.
Okay, now I'm going to give you some teaspoons of water, and I want to hear your voice afterwards. So I
Okay.
just want you to say ah after you swallow. 1, number 2, number 3, number 4, number 5, number 6, number 7, number 8, number 9, and number 10. Okay, now I'm going to give you the cup, and I just want you to take 1 sip. And say ah afterwards.
Okay, so we saw a bunch of water sips there, the 10 sips by teaspoon and the 1 cup sip at the end. Any thoughts? It looked like a pretty normal swallow situation to me. His voice was clear after every swallow. We didn't notice any coughing, any throat clearing. There was no drooling that I could see. Sometimes it's hard to tell in the videos, but I didn't see any. We would say he has a pretty normal swallow. Next, after this, there's one more component at the end here, and that is to have the patient say ah again about a minute after the cup swallow. So this is down at the bottom of that front page of the form. We're going to wait for a minute. We're going to ask the person to say ah again. And we're going to make a final judgment about the quality of the patient's voice. Was it breathy, gurgly, hoarse? Was there a whisper quality to the voice? If any of these are present, even to a mild degree, then we score the patient as abnormal. Okay, so the final portion of the form is part 2, and this is the interpretation portion of the form. If the person has passed the screen, that means there have not been any abnormal results recorded anywhere in parts A, B, or C. If the person has failed, that means there has been at least 1 abnormal result anywhere as we've been going through this, right? So if the person gets in part A has an abnormal voice, right? We think, oh, that sounds like a smoker's voice, abnormal, and then we don't go any farther. But if the voice sounds normal, we go next to having the tongue protrusion and movement from side to side. If that is even a little bit mildly deviated, we stop right there, abnormal, and we quit. If it was completely normal, check off normal, and we keep going on, right? Same idea with all of these water swallows. If there is, at maximum, there can be 3 things wrong. If the person has an abnormal, they have a cough, and they have voice change, and they have drooling. But if you notice even one of those things, then it's abnormal and you quit. If you get all normals right down through here to the last vocal quality judgment after the cup sip, then we are looking at this part D here. Did the person pass? That was everything was normal, or failed, as in we had to stop at any point because of something that was abnormal. All right, so if the person has failed this test, that is anything was abnormal, that means we initiate referral to SLP so that we can do a swallowing assessment. And that is it for the completing the form part. You put it in the patient's chart. You make sure you do the documentation, whether that's IPN or in EPR or whatever. Put something in the progress notes to say that the screen was completed and what the results were, and then follow the protocol for the next steps. So if the person has passed the TOR best, initiating a diet. If the patient has failed, keeping that NPO status in place and having an assessment by SLP. All right, so that's it for today's session. The next component will be the live training, and that will include some practice scoring videos, discussion of site-specific details, logistics, that kind of stuff, and then the practical test where you show us you know what you're doing and are totally comfortable with the TOR best. If you have any questions, like I said, write them down, hang on to them so that we can answer them when we meet you at the live session. All right, take care.